Alan Marmorstein from Mayo Clinic. Welcome, Professor.
Thank you.
Perhaps you can comment on patient recruitment and the importance of caution with regard to clinical trials.
I would be happy to do that. As you know, there was an article in the New England Journal of Medicine as well not long ago that detailed 3 patients who were blinded by stem cell therapies. Now these therapies, as I understand them, were what we call mesenchymal stem cells. So they're the patient's own cells that are extracted on the day of the injection of the stem cells. They're usually extracted from body fat, and then they were injected literally with a syringe as a suspension into the patient's eyes. All 3 patients ended up with increased intraocular pressure, or basically something akin to glaucoma. And in the worst case scenario, one of the 3 patients literally lost light perception as a result. It's a very tragic occurrence, and all 3 of these patients actually paid for this to happen. Now the company that did it is claiming that they were doing a clinical trial, and I can tell you, first of all, if you're paying for the procedure, you're not in a clinical trial. Clinical trials are not something you pay to be in. They're a process that's done as an investigative level, and so the investigator does this and pays, maybe reimburses you, maybe does not, but you should never be paying to be in a clinical trial. The second thing is that there's always an informed consent process, and so there's going to be a document if you're in a clinical trial that you're going to have to sign, and this document is something that has been reviewed by a panel at the university or the hospital where you're at. It's called an institutional review board, and they have legal responsibilities to make sure that you understand exactly what the procedure entails and what are the risks of that procedure. If that risk involves, for instance, in a stem cell therapy to the eye, could you go blind? Could this be a lethal, is there the possibility of death due to this? And all of these, to be honest with you, at the stage that we're at, even death is a possibility. And I'm not looking to scare people with that, but that's how early we are in this process. And so, you know, I've seen a lot of people come to me and say, you know, where can I get stem cell therapy? I'm getting AMD, or I've got this, and I don't want to go blind. It's so early on that I think that for most of us, it's better to sit back and wait. Most of these diseases are not very rapid in their progression. And even if my 10-year window is not long enough, even if it's a 15-year window, for Best disease, for most of the inherited maculopathies, the progression of the disease is such that you've probably got the time to wait. And you're not going to ever lose light perception. You will have impaired vision, but it's not going to be an all or none phenomenon, and that's the other thing. So we get a lot of patients come to us who are newly diagnosed with these diseases, and they're scared to death. You know, oh my God, my doctor told me I have Best disease, or I have Stargardt's disease, or I have AMD, and I'm going to go blind. And that blindness is not what we sighted people perceive as blindness. I'll tell you, when I went in the eye field and I said and I thought blindness, I thought of plus and minus. I see or I don't. There are so many degrees in between, it's almost unfathomable. And for the vast, vast majority of people with these diseases, they never will walk with a cane. And the impairment really is going to be akin to simply having a fist right in front of your face that won't go away no matter where you look. It's hard to see somebody's face. It may be difficult to read a newspaper or follow a television program, but it's not going to be that you're stuck in a dark room without the ability to find the walls, the door, the food on the plate in front of you, or whatever. Most of us, and when I say most, I mean the very, very large majority who have these diseases or are diagnosed with these diseases, will retain enough vision to have a very active and functional lifestyle.
Talking about the translational implications of your work, from a patient's perspective, what should their expectations be in 3, 5, 10, or 15 years?
So the first thing I want to say about that is that we have a hard time finding people for clinical studies. And when I say that, it's not that there aren't volunteers, it's that people haven't been well documented. I've been working with a company, and I won't name who they are, but I've been working with a company that's trying to do a gene therapy trial, for example. And they need to put together the endpoints for the FDA to approve the trial. So they came to us and they said, you know, we're looking at your institution and several others, and we would like to know if you have retrospective records on patients for 5 years where you can give us fundus photos and OCTs and document progression of the disease so that we can determine what our endpoints are going to be. I had 38 people who came up in our database when I went and I looked, and only one fit the criteria that they were looking for. Now, that one, had this been a clinical trial, would be the only one of the 38, and it's a rare disease. Would be the only one of the 38 who could enroll in that trial because he was the only one who had sufficient clinical documentation. Very often, private practice retina specialists will have you in their office, and this is more for the inherited diseases. The AMD people, you're getting Lucentis or whatever, and so you're seeing your doctor a lot and you're getting well documented. But very often people with BESTs, or less Stargardts now because there's more clinical trials, but BESTs, certainly Sorsby's and so on. The doctor says, you know, there's nothing we can do, sorry. That's not true. What you can do is document your disease and your disease progression so that when we do have clinical trials ready in 3 years or 5 years or 10 years, if you choose to participate, you have sufficient documentation that we can enroll you. We need to know, have you had the genetic testing? I can tell you for an inherited maculopathy, if you haven't had genetic testing, you are not diagnosed, okay? You need to have good color fundus photos. You should have OCT records. There are other tests depending on the disease, maybe it's visual fields and so on. And so I would strongly advise patients to confer with their physician about what are the array of tests that are appropriate to be fully, properly diagnosed, and to have those tests done periodically so that the progression of the disease is documented, and so that down the road when clinical trials are available, or if the treatments become approved, you have a basis in which to apply them and determine their effectiveness. And this is very important for us. The other thing is very often the clinicians who are telling you that there's nothing that can be done are not really taking into account that there are side effects that we can fix. For example, in Best disease, cystoid macular edema is a common side effect. And this is something that we see very easily and very early if we look at OCT imaging. So on its own, when it's early, it's not something a patient would experience that would cause any problems to their vision, but left unchecked, it can increase the progression of vision loss. But there are things we can do to solve that. And I've seen we had a patient who came in who had such bad CME, his retina looked literally like a piece of Swiss cheese, holes everywhere. And we were able to give him, not me obviously because I'm a PhD, but you know, the guys I work with were able to give him treatment with a small molecule drug that resolved it completely in 3 weeks. Everybody was amazed, but it saved his macula and gave him years, I think, of extra vision that he might not otherwise have had. So you don't need to be checked every day, but I think it's reasonable for somebody who's diagnosed with one of these diseases to sit down with their physician and say, how frequently should I come back and be checked for these things, and what are the tests then that you need to do?
So I think that's given us a wonderful overview of the trajectory and the types of research that you're conducting. To come back to that final question, once you've got sufficient patients in clinical trials, are there specific areas that you see as being on the leading edge? You know, which types of patients are going to be most amenable to the therapeutic approaches that we're talking about? If we stratify your best patients, for example.
Well, that's a difficult thing to answer. I think it depends on the way that things go. I'm putting my eggs in the basket of cell-based therapy. There are others who are looking at gene therapy, for example. Gene therapy is a little bit more mature, maybe. We have products that are approved, at least for use in Europe, for gene therapy, not in the eye, mind you, but in other diseases. There are issues there with reimbursement from insurance companies and so on that yet need to be worked out. Spark Therapeutics, as I understand it, is going for FDA approval of their gene therapy for Leber's congenital amaurosis due to RPE65 mutations, and that hopefully will become approved. And again, they're going to have to work that out, but that's a very small population of patients. Right. For Best disease, there are people looking at gene therapy right now, certainly for the recessive version, autosomal recessive bestrophinopathy. We're a little ways from getting that FDA approval, I think, there. But we don't know yet whether it's effective. Is gene therapy effective for ARB? Is cell therapy what you need for ARB? Is gene therapy going to be effective for Best disease? Is a cell-based replacement type therapy like I'm interested in? We're just not there yet. And so to say this population or that population would be, beyond speculative. But what I will say is that the patient who comes in and has that documentation, who's had the genetic testing, who's had a thorough characterization of the progression and time course of their disease, is the patient that we would be looking for if we're testing something in early trials.
Are you looking at any ancillary biomarkers?
Yes, and yes, but we don't have them yet. Certainly in the case of Best disease, we really don't have them yet. For other diseases, maybe things are coming along more. It's an area, though, that I'm not familiar enough with to address, the way that you probably want them addressed.
So as you see it, you're developing an ecosystem that will support both gene therapy and a stem cell-based approach, either alone or in combination with each other.
On the broader scale of retinal degeneration and macular degeneration, yes. I think it's going to be a combination of both. Certainly in inherited diseases where the gene is missing, gene replacement therapy is gene therapy. And we're at the point again where, at least in other countries, there are approved therapies. There probably will be very soon in the US. And I think, it's been a slow process. And as more therapies get approved and as the billing issues with insurance and so on get worked out, I think you're going to see an exponential increase in gene therapies that become available. And then maybe they will go beyond gene replacement therapy. Maybe we'll be able to do gene knockdown therapies. There are certainly people who are working on that for dominant diseases like Best disease. And then the cell therapies are coming along, and I think actually we've got a bit of a head of steam that's beyond where maybe gene therapy is today as well. The FDA looks at autologous tissues differently than it does things like viral vectors. One of the reasons that some of these stem cell clinics that are not doing very good work can do this is because they're using your cells. If they go in and they extract cells from a fat biopsy that they take from you as they're doing the procedure, because it's your cell and because they haven't actually altered it in any way, they're not regulated by the FDA the same way that we are if we're going to do something like reprogram your skin cells to make stem cells and then turn those into yet another cell type. That's something the FDA regulates very highly. Now, having said that, the FDA is also looking into what changes they need to make to regulate these things. And I think that's I realize maybe I'm getting off topic from the question that you asked, but to me this is something very important. There are 550 or so stem cell clinics currently operating in the United States, and not any of them, to my knowledge, and maybe I'm wrong, maybe there's something that I'm not aware of, but none of them are offering an FDA-approved therapy. And very few of them are offering what you would call a legitimate clinical trial because they're asking you for money to do the work. So, getting back to an earlier question, in essence, let the buyer beware. Do educate yourself with it. Don't say, I don't want to be in the dark, I got to get an injection in my eye tomorrow, because if you do, you may find yourself in the dark a heck of a lot quicker than if you don't.
Right. So obviously, for a patient to go to clinicaltrials.gov, check the legitimacy of a trial on that setting.
Well, being on clinicaltrials.gov does not make a trial legitimate. I can't say much more about that. We all list our trials there, but just because the trial is there, that doesn't mean the FDA has looked at or approved the trial. Okay.
So that's my second question. Is there another site, a consumer report, so to speak, for this area that might be more helpful to patients?
But there are sources from which you can educate yourself if you really want to do them. There's in the stem cell area, there's a blog. It's run by a fellow named Paul Knopfler, and he is really on top of what's going on in the stem cell field across the board. Not focused on the eye, mind you. I mean across the board and everything. And there are legitimate reasons, by the way, why people do use mesenchymal stem cells. The things that some of these clinics are doing, it's actually very effective in joint disease, and it's in clinical trials. It's not an approved therapy there, though. But people who've been doing that I know are finding it very effective. The thing is, I hate to quote Franklin Roosevelt, but the biggest thing we have to fear is fear itself. Don't be afraid. You get the diagnosis, you didn't go in the doctor's office in a world of darkness. You went in because you had some changes to your vision. or maybe somebody just noticed something on an eye exam, on a dilated fundus exam that wasn't there before. And you know, it's scary, and I understand that. And I've encountered so many people with a new diagnosis who are scared, you know, I'm going to go blind. It's a slow process for almost all of us, and it's almost never in macular diseases that you lose the ability to perceive light and observe spatial cues and so on. And actually, if nothing else, the stress that you put on yourself through this fear may be the biggest thing that contributes to accelerating the disease as well.
You know, I guess the last question really is, you know, how you, if a patient is in a situation, many retinal specialists have different thresholds for testing. And some patients feel uncomfortable going and researching the internet, and they're going to ask the doctor for certain tests. If a patient feels that they're not getting the full repertoire, who do they go to at the Mayo Clinic?
Okay, I get to give a plug for the Mayo Clinic. We have an appointment hotline, and you can find it at the Mayo Clinic. It's www.mayo.com. Just search at that website for ophthalmology, or call our general appointment hotline and set up an ophthalmology appointment, and we're happy to see you. What I would say is, if you're not getting what you want, go to somewhere else, be it the Mayo Clinic or someone else. You're in the driver's seat as the patient. They're your eyes. They're not the doctor's.
Professor, thank you so much for this most insightful and enriching interview. Thank you again, and we look forward to watching and learning as your research unfolds.
Thank you. Very welcome.
Thank you.